just on the side of the patellar tendon, patellar tendon, on that tibia, okay? I don't want to dig in that fat pad. I don't want to push on that tibia or that patellar tendon too much. I want to be right on that tibia. As I start to go down, I'm going to lunge using my body weight, over pressure using my hands. Now you guys go there there's no restriction. People that have problems, it's stuck. It's like you're pushing on a piece of wood. Okay, it just doesn't want to go. So you have to sit there, over pressure, over pressure, over pressure. I'm not going to go back up and down, not this, but it's stay down here, over pressure. I might hold it for a count or two, come back out, back, there. But it's not nearly as what you guys can do, where you guys just snap into that end range without any sort of pressure. These people are generally 10 to 15 degrees off. I always ask, how are they feeling as I'm doing? Usually you can get a good idea by their face, but some people are very stoic and don't tell you things, so try to gauge them. How's this feeling? How's this feeling? Where are you feeling it? Okay? As their irritability starts to decline, or maybe they come in, I had a guy medial meniscus, and he was 6 days post-op, but he had no irritability, but he was missing about 8 degrees of extension or something like that. I might elect to do this one, where I counterbalance here. I use that same kind of grip where I try to put the tibial tuberosity right here, and I try to put most of the pressure on the outer edges, okay, not on that tibial tuberosity. Here, lock my elbows out, and I just drive down on my left arm. I'm not doing this, where I'm really cranking it. I'm just stabilizing it here. I'm pushing down with my left, trying to create that. Does that make sense? Now, some of you may have seen this in the clinic. What's this versus this? What's the difference?
The first one is like hyperextension.
Yeah, so imagine this is more passive range of motion techniques. So don't get confused, because oftentimes they do them in a package in the clinic, right? If someone's limited here and they push down on both sides of the joint, all I'm doing is this. It's passive range. So femur, tibia, drive that down. It's passive range of motion. It does work very nicely. It's very sore for a lot of patients. But immobilization is when I'm here and the adjacent joint surfaces are moving on one another. One's stable, one's moving. Okay? Does that make sense? So you're